Hello again. Welcome to Chapter 9, where we're going to talk about therapies for chronic obstructive pulmonary disorder. This was originally recorded as one long video, and I have now broken it up into three shorter installments. This is a little bit of an aside for you. Inhaled therapy has been around for as long as we've probably been inhaling, burning leaves, if you know what I mean, probably for at least since the first Europeans came to America and partook in tobacco smoking and things that were occurring here with the Aboriginal Americans. But I want to make a point, and that is that we will see, or we are seeing some of the same strategies, if you will, that we're seeing now with marijuana. Um, you know, this is saying that cigarettes that will help you relieve your asthma, if you know what I mean, and that things are beneficial. I'm not saying that anything is or isn't, but I can tell you that at least from the history, that people will tend to accentuate the positive and eliminate the negative when trying to legalize certain things. I'm not taking a position, like I said. Just understand that there's a lot more data that needs to shake out before we really know what's going on um, in terms of the health benefits or the risks. So, given that we're dealing with with the chronic obstructive pulmonary disorder, what we're dealing with here is primarily the conducting pathways, and in the conducting pathways, we're talking about down here in the bronchioles and leading down to the beginnings of the alveolar sacs. So we're dealing with conduction of air in and gases in and out of the lungs. That's what we mean by obstructive, is that you're having trouble moving the air. You may have capacity, but you can't move it. Like liquids, gases move through these tubes with the same kinetics and behaviors as liquid, and that's Posses Law. That is to say that the resistance is 8 times the length times the viscosity divided by pi r to the fourth. So what we're saying here is that resistance is proportional to length, that as the length increases, resistance will also increase in the same proportion. Twice the length, twice the resistance. Now, length doesn't change very much in our lungs. It would be extremely unusual, perhaps over the course of development as a person moves from infant size to an adult, maybe there's a little bit of change in length. Resistance is also proportional to viscosity. That's the Greek letter eta here, the thickness of the fluid or gas. Again, this does not normally become a factor in movement of air, except in very, very extreme conditions, and even then, not as much as it might seem. So we're going to just kind of ignore those two factors. They're part of the law, but they aren't the real story. The real story is the radius to the fourth power, and it's inversely proportional. That is to say, as radius diminishes, resistance goes up big time. As radius increases, resistance goes down big time to the fourth power. So that's a dramatic change as radius changes. So let's, for instance, if you were to double the radius, then that would mean that you would have 16 times the flow. So 2 times 2 times 2 times 2. So that would be a total of 16. Or if you cut the flow in half, you would have 1/16 of the flow, or roughly 5%, a little bit more, 6%. And how we control ventilation is important as well. And we have multiple redundant systems that have feedback loops in them in order to maintain the appropriate ventilation to facilitate proper gas exchange and meet metabolic need. So we have chemoreceptors. Those are located in different areas that feed into a central nervous system center, and then that center then sends out action potentials to things like the diaphragm and or accessory muscles to facilitate ventilation. Remember that we ventilate in order to sustain an appropriate gradient, about 100 millimeters of mercury of oxygen, roughly about 40 or a little bit less millimeters of CO2 to facilitate unidirectional flow of oxygen in and CO2 out. So those receptors that I mentioned, they include chemoreceptors for CO2 as well as acid. They are sort of an overlapping set of receptors, and they are not the same. They're two different populations. We also have this secondary set of receptors called O2 receptors. This is what we call oxygen drive, and this is sort of known as CO2 drive. CO2 drive is normally a lot stronger than oxygen drive. But if someone is COPD, quite often they have elevated CO2 levels, and so their CO2 levels are actually knocked out, and they're relying on their oxygen drive to regulate sort of that involuntary changes in respiration. Again, they feed into a neural respiratory or ventilatory control center that then sends out I'm sorry, I'm going the wrong way here, sends out signals to the diaphragm in order to increase and change the lung volume at a given rate and depth. And then that, again, feeds back into this center and will regulate it, sort of in a negative feedback pathway. This is just another picture of that. So these chemoreceptors are found down in the sort of the brainstem, the pons area, and a little bit lower. There are some stretch receptors in there. This is all working together. So you have chemoreceptors that are sort of the drive, if you will, and then some things like irritant and so forth that will negate depth. So they works together in multiple feedback pathways. That can be overridden, by the way, voluntarily. Absent of voluntary control, the breathing rate and depth is mostly governed by the autonomic nervous system. When it comes to the sympathetic activation, that's done via epinephrine release. So there isn't a direct innervation of sympathetic neurons on the bronchi, but they do have, in this case specifically beta 2, but they're beta adrenoreceptors like we talked about earlier, that will modulate smooth muscle relaxation and thus dilation. So you relax the smooth muscles, the bronchi get bigger. The beta 2s will also mediate inhibition of secretion, so you dry out and enlarge. On the other hand, we have the vagus nerve, which is cranial nerve 10, is directly innervating the bronchi and some of the glands in the bronchi to cause smooth muscle tension increase as well as secretion. So on the parasympathetic side we have nerves, and on the sympathetic side we have a hormonal epinephrine situation. Now, I've seen the looks on your faces when I start talking receptors. I understand there's a little bit of resistance here, a little bit of hesitation. Just trust me on this stuff. If you get this down just a little bit at a time, just try these out for size. So on the sympathetic side, we have this adrenergic receptor. It's a beta adrenergic receptor, and in pulmonary tissue, it's well understood to be beta 2, the number 2 isoform. Any type of beta agonist will do these things. Certainly epinephrine, norepinephrine will, and others. Now this beta 2 adrenoreceptor is a G protein coupled receptor. That's a G protein there. And this one will turn on an enzyme called adenylate cyclase. This is an enzyme that basically creates a second message. It takes ATP, it hydrolyzes it, and creates a circular cyclic AMP second message. That will in turn turn on the enzymes that create nitric oxide and mediate relaxation. Nitric oxide is a well understood vasodilator, and now we're seeing that it actually has a role in smooth muscle relaxation in pulmonary tissue as well. On the parasympathetic side, we have direct innervation, and we secrete acetylcholine onto these two muscarinic receptors. Now, what's happening here is we're mediating contraction, but let me explain. One receptor over here is actually going to inhibit and dial down the relaxation pathway. This G protein is actually turning off adenylate cyclase, making nitric oxide go down. So we're shutting down the relaxation pathway, leading to more, higher tension in the muscle. And this other muscarinic receptor is turning on an enzyme called phospholipase C, the C type of phospholipase. And we have phospholipids in the plasma membrane, and so this enzyme, once it's turned on, starts cleaving phospholipids. And it creates these two molecules, IP3 and DAG, diacylglycerol. Well, IP3 will go and activate calcium channels in the sarcoplasmic reticulum, release calcium, and when we release calcium, we get contraction. So a cool little off switch on the relaxation and an on switch on the contraction. Now, things that will activate this above and beyond just acetylcholine, physical irritants can also trigger some of this. Inflammatory mediators as well. So these receptors may be receptive to other types of cytokines, and there may be some other initiators of this pathway when it comes to inflammation and irritation. Asthma is a pretty good example model system of chronic obstructive pulmonary disease. And what makes asthma interesting is that it can occur over the span of an entire life. You don't have to have pulmonary fibrosis. You don't have to have emphysema and all these other complications to have asthma. Young kids have asthma, and their lungs are beautiful and clean. What we have going on here is that you have a shutdown of the tubes that move airway. The airways get inflamed. The inflammation will drive mitosis and proliferation of smooth muscle. So you get this thickening of the pulmonary muscular wall that's much more stiff and much less supple. The inflammation will also drive parasympathetic secretion type responses, and so a combination of reduced radius and increased secretion make asthma very hard to move volume. And what we call forced expiratory volume diminishes. Some people, when they talk about severe asthma, will refer to air trapping. That is to say, they might be able to get air in, but they can't get it back out. And so this is one way of measuring it. It is how fast or how much air, the volume of air we can move in a given period of time when we use all of our respiratory muscles to exhale. Under normal conditions, we can expire very, very quickly within roughly 2 seconds. So if this is 1 second and here's 2 seconds, we generally get to our maximum exhalation volume. So expiratory reserve volume and so forth. But when we have obstructive disease, you can't do it. It takes more on the order. So here's 2 seconds. Here's about 3 seconds, 4 seconds, 5. You can see that it might take as much as 6 seconds or more to achieve the same expiratory volume as a person who has normal passageways in their lungs. And that's why we call it obstructive. You've reduced the radius, which means you can only move so much volume. On the left, we see a normal airway with a given wall thickness, not very many secretions. There would be a mild layer of secretions on here in order to condition the air and trap dust particles. In an asthmatic airway, you can see that there's an increase in the thickness of the walls, a significant diminishment of diameter. We're not seeing a whole lot of fluid at this point. They may be able to move air that's appropriate to meet metabolic need, but when we get an irritant, then all of a sudden that triggers a cascade of hyperactive inflammation, which includes secretion and additional swelling of the tissues, really clamping down on those airways, making it extremely difficult to move air properly and certainly not sufficient to meet metabolic need. The etiology or the pathophysiology of asthma is complicated and involves a whole bunch of different types of soluble cytokine signaling. What we're seeing, at least to try to summarize it a little bit, is that we see this increase in T helper 2 cells. These are thymocytes then there are different kinds. But what we seem to see is that that somehow this T helper cell, either because of genetic predisposition or in some cases some circumstantial, there is some evidence that we may be living lives that are too clean, if you know what I mean. So if we don't develop tolerance either from Th1s or if we have genes that predispose us to allergies, we see this elevation of the T helper 2. That in turn that T helper 2 will release cytokines that will activate B cells that secrete this IgE. It's an immunoglobulin type E. And IgEs will not only bind allergens, will bind immunogens or antigens, if you will. That's actually the right term, antigen. But they also, part of their antibody will attach to this this granulocyte cell that's very, very similar to a basophil, but it's called a mast cell. And so what happens is these IgE antibodies, in combination with the mast cell, when they bind an allergen, will trigger degranulation of the mast cell, releasing histamines and other cytokines that lead to physiologic inflammation and tissue remodeling in the chronic setting. So T helper 2s, cytokines, the B cells make IgE. IgE will then activate mast cells in the presence of an antigen of some kind. The physiologic effects, again, remodeling in the chronic phase, but in the acute phase, it'll lead to bronchospasm. So a massive increase in smooth muscle tension, secretion, and leading to overall obstruction. So it's a kind of a hypersensitivity, anaphylactic type situation. But all sorts of irritants seem to be able to do this. And people who are sort of predisposed to allergies, turns out these IgEs are really non-specific. They will react with a whole bunch of different molecules. And so they are much more likely than somebody who's developed tolerance either from Th1 or the shape of their receptors leads to much fewer or less likelihood of a response like this. So it's a hypersensitivity response. And so here again, the primary mediator, I guess we should sort of dial it down just a little bit. The primary mediator is immunoglobulin E. And again, that's activating degranulation of mast cells. We're releasing a ton of histamine and other molecules that will mediate inflammation and remodeling. Since asthma can be a progressive disease, that is to say, every time you have an attack or every time you have some sort of an irritant leading to inflammation, it can progress and worsen over time. So when it comes to asthma management, the first thing is to make sure that we're relieving any symptoms that are already present. So using an inhaler or using things in order to sustain or maintain what lung function we have. Even a couple of attacks, you'll already begin to create relatively irreparable changes to the architecture of the lungs. So we're going to sustain function, we're going to alleviate symptoms, and then by understanding mechanism of what's driving this, we can also reduce future risk. And a lot of the new research is coming this way because by the time you've relieved symptoms here, the symptoms have been present for how long? And the architecture is already remodeling in that time. So what we try to do is control whatever is occurring at the time if necessary, but in addition, trying to reduce the possibility that it ever occurs in the first place. Given the prevalence of asthma, there are a whole bunch of products on the market. It's a very, very large market from population standpoint, not only in the United States but around the world. And the other big advantage with COPD is that you're able to deliver agents directly on the interior lining of the bronchioles and the airways, or perhaps all the way down in the alveoli. And so we have combinations. We have the sort of the bronchodilators that are used for acute situations. We've got the anti-inflammatories, which are preventive. And you might see a commercial or two out there saying this is not for acute situations, it's for prevention. And then there are even combinations now that do a little bit of both. That they not only will reduce acute symptoms, but also work to prevent future attacks. As occupational therapists, one of the big goals of understanding pharmacology is to help assist you in developing a pharmacologic routine, a workflow, if you will, that's not only effective but correct to avoid toxicities and maximize therapeutic benefits. And one of those things that you can really make a difference on is understanding the proper use of the different kinds of inhalers out there. We've all seen these, but it's actually quite surprising how few people really understand how to use these correctly. So good training, make sure that if you're assisting someone, that you yourself understand completely how and when to use the inhaler properly. And it can be something as simple as holding it a couple inches away for certain types of drugs, or in the mouth. And you're not going to do that for corticosteroids. You want to make sure you're doing the right method for the drug and the delivery. Sometimes that may involve using a spacer, or some other form of modification to the normal thing. These do not all work the same way. The corticosteroids, if you do it in the mouth, may end up penetrating the oral epithelium and causing all kinds of side effects that are unintended. We want to get those steroids down in the lungs, not in the gastrointestinal tract, if you know what I mean. So considering using a spacer, sometimes known as an air chamber, depending on the type of drug and medication, and proper use is very, very important. Otherwise, it's just wasted time, and the drug is probably going to the wrong place, causing unintended side effects. Another challenge that you will be faced with is in somebody who has reduced function in their hands. It does require some level of manual dexterity, and this could be a significant challenge to someone with osteo or rheumatoid arthritis in their hands, or perhaps someone who's lost digits or paralysis and so forth. So you'll have to be creative and try to come up with ways to help with folks who have limited or no hand function to use their inhalers with any significant success. In terms of drug therapy, the frontline drugs for asthma and other forms of COPD are the bronchodilators. At the top of that list are the beta 2 agonists like albuterol that we talked about. Albuterol and other beta 2s, again, what we want to do is we want to be as specific as possible. These are adrenergic agonists, and remember that adrenergic and sympathetic signals are divergent. They want to act as one unit. So if we can dial it down to a specific receptor, that can go a long way to mediating some significant side effects like heart rate, and so forth, especially in somebody who has heart disease. We can also, if we can't use an adrenergic agonist, if the side effect profile is too great, then we could go with an anti-parasympathetic. Not quite as powerful, but certainly worthy of consideration. So the anticholinergics, these are the parasympathetolytics. These ones are blocking the secretion pathway, blocking the bronchoconstriction pathway. And then the third drug, it's called theophylline. And theophylline fits in this category called a methylxanthine. It's not as common as it used to be. It's kind of gone by the wayside. I might talk about it later on, but I'm not going to spend a ton of time. The big front line, the ones that's got the best specificity, are the beta 2s. Also, in terms of the preventive side, we have the anti-inflammatory drugs, and the categories here include inhaled or sometimes oral corticosteroids. Corticosteroids do have an immune suppressing function, which is why if you get stressed out pretty significantly, you're likely to get sick, or more likely, I should say. Those are nice. They penetrate membranes very well, but then they also will spread to other areas and cause side effects, which can be fairly significant. So that's somebody who has pretty serious asthma before they usually give corticosteroids. What's the work in progress, the ones that are kind of coming along in terms of preventing and so forth, are what are called leukotriene. That's a form of cytokine. It's a pro-inflammatory cytokine. These are antagonists. We also have receptor antagonists, by the way, that block the receptors to leukotrienes. And then these interesting molecules known as mast cell stabilizers. If you remember from a few slides back, I showed you that the IgE in combination with an allergen will activate degranulation of mast cells. So what we're saying with stabilizers is that it makes it harder or less likely for those mast cells to degranulate. And here is just a little bit of a reminder on some mechanism here. So the beta 2 agonists are going to, again, we're talking about a G protein coupled receptor that that creates cyclic AMP and then causes nitric oxide to mediate smooth muscle relaxation. Now let's throw in the methylxanthines like theophylline. Okay, theophylline is a phosphodiesterase inhibitor, and phosphodiesterases are what cleave and destroy nitric oxide. So if you inhibit the phosphodiesterase, you will keep nitric oxide around longer, which means more smooth muscle relaxation. Or we could go after the parasympathetic pathway. So with some anticholinergic drugs, we reduce the parasympathetic signaling on the airways. So, and you can use more than one of these at a time in order to surround, depending on how severe the asthma is. Now let's bring a little bit of pharmacokinetics into the picture. If you have an acute asthmatic attack and you need something now and you need something powerful, then you would use something that's short acting. That acts within 5 to 10 minutes, during that sort of period of crisis, if you will. I'm not going to worry about the individual agents, but again, it has to do with the kinetics of the drug. So a short-acting one will have, will be active in 5 to 10 minutes, last for maybe an hour or so, with overall effect somewhere in the 4 to 6 range. The long-active, you're not going to use in an attack because it just takes too long. So, but they do work well for 4 to 12 hours, 2 to 4 hours, and so double the length of the short acting, and will serve as what we call a prophylaxis, that is to say, a protection against another attack. So they don't work as quickly, but they stick around and keep attacks from occurring, especially if a patient finds themselves in a high probability environment for irritation and activation of inflammation. Side effects of beta agonists, which are our frontline agents, are sympathetic in nature. That is, increased heart rate, perhaps anxiety and tremor, headache, vascular constriction, which could exacerbate something like coronary artery disease or along those lines. And also some of the beneficial side effects of a beta-2 agonist are that you have less fluid moving out of the capillaries into extracellular space. So it might be able to reduce edema a little bit if they have some signs of pulmonary edema. There certainly seems to dial down some parasympathetic neuron transmission, again, through mechanisms that I haven't fully investigated myself. Certainly anti-secretory, because again, we're sympathetic, so that would block secretion pathways. But what's particularly interesting about beta-2s is that you'll have reduced activation of immune cells like neutrophils and the reduced adherence of bacteria. So there's some really interesting beneficial side effects in addition to pathological side effects. Here's another deep hole here. You can talk about categorizing beta-2 agonists like the different, catecholamines or non-catecholamines. And again, I'm not going to get too far into this. We have sort of have short and long acting sort of situations. Just a little bit more mechanism if you didn't already understand what's going on. We are trying to relax bronchial muscle. Some of the key things about therapy is that we need to make sure that they take and use their bronchodilators correctly. This is where you guys can really make a difference. That they know how to use their inhalers properly. That sometimes more is not better. Make sure that they are have the patients show you how to use the devices correctly, and keep an eye out for sympathetic side effects, especially with those beta agonists. If they're at risk of heart issues, keep a close watch on that. And understand potential interactions with other drugs, et cetera, et cetera. We're going to pause right here, and we will pick up in the next video, next slide, moving on to additional agents for chronic obstructive pulmonary disorder.